cardiology of hematopoiesis, which is fantastic at this point, and today you receive CBC stuff, right? So you guys know all about CBCs. When I throw out these terms, you'll be like, yep, got it. Already know it, which is perfect. But I know that's not the way it really is. So don't worry, I'm going to describe everything as I go along. And some of it you might feel is a repeat of this morning. I talked to him just now. He said that is absolutely not true. But we'll see how you feel after this. Today, I break it up because whenever you talk about anemias, I want you to have a general idea because honestly, most anemias present almost exactly the same. There might be some difference in the way, like their history perhaps, like you'll find some kind of evidence of a bleed, or in females maybe heavy menstrual bleeding, something, or maybe a family history of lots of people having anemia. But really those are your main cues clinically without lab to tell you the difference between them. Because honestly, a lot of it will be lab to differentiate these. So we'll kind of focus on that. I'll give you a little bit of clinical, like HMP stuff, but a lot of it's the lab, because that's what you're going to see, and that's what you're going to hone in on whenever you're doing test questions, is what differentiates them between each other is the lab. And when you're seeing patients, not all lab tests, but. And then at the end of it, yes, tomorrow, at the end, I'll also cover polycythemia vera. Polycythemia vera is the opposite of anemias. It's kind of like, it's exactly the opposite, so we'll just cover it kind of, because it doesn't really fit anywhere else that well, unless, well, anyway. What you may notice from this section is missing is, if you were looking ahead, is thrombotic disorders or cardiovascular, like blood clotting disorders, and those we'll cover with the cardiology section, because that's usually who is going to monitor you and treat you with the Coumadin, things like the anti-clotting drugs. So you'll get that, but in cardiology, in case you're wondering. Looked over and you're like, something's missing. Maybe you didn't. All right. So basically anemia is defined as a decrease in red blood cell mass. We use some handy measurements like hemoglobin and hematocrit to monitor this. And the main problem with anemia is you don't have enough hemoglobin, so you can't get enough oxygen to the areas that need it. Specifically, and most importantly, your brain and your heart. You can have anemia for a lot of different reasons. The ones I want you to think about whenever you're trying to figure out or suss out why are they anemic is it a problem making red blood cells, or is it a problem losing red blood cells? And you can lose red blood cells two different ways. One is that you have an acute bleed, and that's easier than a chronic bleed to figure out. Or it could be that they're destroying red blood cells with the hemolytic process, which we'll talk about tomorrow. So their body could just be munching up the red blood cells. So those are the two things. First, separate them into those two, and then go into the two different ways you have blood loss. So here are our measurements. We have hemoglobin and hematocrit, your red blood cells, your MCV, which is your mean corpuscular volume. And that's what we'll focus on the most whenever we're talking about trying to figure out what kind of anemia, because it's really the first clue you'll look at, whether it's a large red blood cell or a small red blood cell on peripheral smear or in your red blood cell indices. If it's normal, that's a whole other section of diseases too, and we'll talk about that. The other is the RDW, that's your red blood cell distribution width. This one, I don't know, it's not terribly useful, but it does say there's lots of different cells of lots of different sizes in this sample. And that's a little strange, and that goes along with some disease states as well. And then MCHC, I always think the part that, because this determines whether we call it hypochromic or hyperchromic. Most of the time what you'll find is hypochromic goes with microcytic. If it's small, it's because it doesn't have enough hemoglobin, which means it doesn't have heme, which is what gives it the color, right? So if it's small, it's probably not going to have a lot of color to it either, and it will be hypochromic. And I always see, it's called mean corpuscular hemoglobin concentration, but I always consider that it's CH to be chromic in the middle, because I always remind, that's how I remember that it goes along with the hypo or hyperchromic designation. All right, what I want to point out to you is that all of these measurements are a percentage or a ratio. So they're all out of whole blood. It's not just a number. It's always going to be out of the total amount of whole blood. And that will become important whenever you consider special considerations anemia, when you're looking at their blood. I'll show that, I'll explain that in a few minutes, but excuse me. That was attractive. Okay, so normal ranges for hemoglobin. You have males 13 to 17, females 12 to 15. Usually in males are like at 12, females around 10. You start to get really concerned that you need to work this up. Anything under that should pique your interest, of course. But those are oftentimes when people start to become symptomatic, kind of symptomatic. People are really good, especially if it happens over a long time. If you're losing red blood cells from a chronic GI blood loss, people are really good at compensating for a long time. So it's not as though you get to show up the minute they become anemic most of the time. It takes them a while before they become symptomatic enough that they say, I gotta go in, I am so tired. Or their family says, you're not doing anything anymore, you gotta go in. And so that's why most of the time when we pick up an anemia, it's kind of an incidental finding because it takes a long time for people to be symptomatic or they're there for something else. It's very rare that you will catch an anemia when it's not really bad from symptomatic findings, just so you know. So your hematocrit, you have the normal values there. I don't necessarily want you to spend a lot of time memorizing those. You'll have normal values when it comes time to a test. I want you to have an idea in your head though, kind of like when I'm going to worry about somebody, you know, so that you can look at a test value and be like, that's not good, that's not bad. You'll have little arrows and it'll say hi next to it, so you'll have some hints whenever you look at lab values. I'm not going to test you for something that isn't real life, but. And the other is your red blood cells. They have normal ranges for that, and those are pretty close to each other in male and females. I want you to understand this. This is when you do H&Ps. Always write out your labs this way. There you have your X, and this thing you'll want to learn how to do that by the time you get into clinical. So that, and more importantly, you want to know what goes in those boxes so that whenever you're looking at something, you'll know what the heck they're talking about. Because they don't usually label it for you. They don't put hematocrit and then the number next to it. You just need to know what goes there by the time you start functioning in the real world, especially in a hospital setting. So this is manifestations. How does the body show that it is anemic, that it's having a problem with lack of hemoglobin? So the vasculature shunt, your body is really good at trying to deal with this. So what it will do is when there is decreased blood volume or hemoglobin, it will shunt blood from less important areas to important areas. And they will do that by producing new blood vessels off of already existing blood vessels in areas like the brain and the heart, and it will take blood from the skin and the kidneys. It will do that in chronic anemia, and then also when you have an acute bleed, it says there, it will shunt blood from the mesenteric and iliac beds to the major areas that need to have blood, like your brain and heart. And so whenever it does that, it will vasoconstrict in places like your skin to send it to your heart and your brain, which is why you have pallor. Heart will also play a role whenever you start to get, although not for a long time because it's very metabolically expensive for the heart to start going into overgear and increasing cardiac output. That's what we use that's one of the measurements we use. Your heart will stay put at normal functioning level for a long time until the anemia gets really severe, so your hemoglobin drops to about a 7. That's pretty bad, and that's when the heart will say, okay, this is getting serious. I got to start increasing my output, which takes a lot of energy. So there's a lot of, they try to avoid it if possible. I get really anthropomorphic when I talk about the body, which might upset some people, but anyway. So signs that your heart is upping its game would be tachycardia, because it's beating faster, it's trying to put out more output, and then that capillary pulsation, also called a bounding pulse. A bounding pulse never made much sense to me until I realized it was the heart doing it, because you would think if you were anemic, you wouldn't have a bounding pulse, right? Because you have volume depletion many times. But your heart is pushing so hard against increased vascular pressure that it becomes this bounding pulse. It's hard, it goes away quickly. That's why they call it bounding, or the water hammer pulse, after that toy, which you've probably never seen a water hammer. But it comes quickly and then goes down. So you should associate a bounding pulse or a water hammer pulse with severe anemia. Usually you don't, a patient probably won't tell you that they're tachycardic or that they feel their heart beating very hard, unless this person already has underlying cardiovascular disease. And then it could be that they're very sensitive to any increase in cardiac output, and they might have some chest pain. But like I said, this isn't going to happen until we're very serious anyway with the anemia, to the point where they almost need a transfusion most of the time, by the time they get to this point where they have increased cardiac output to deal with it. Your lungs play a role. They start to, because and usually after your heart starts to increase its output, its lung has to have to work harder to try to oxygenate all this blood. So usually it's a secondary issue. These people will show up with tachycardia as well as increased respiratory rate. Because the lungs are working so hard, they will have dyspnea on exertion and orthopnea. When they're laying down, it's harder for them to breathe. Dyspnea is just, painful breathing when you're moving around on exertion. I always forget that you guys are I'm going to try to define as many things as I go along, because it's really hard at first to get to this, to get the nomenclature down. And then the last and most important and most reasonable response to anemia is increased red blood cell production. So your body tries to help this situation by, whenever you have decreased red blood cell volume, your body will start to put out erythropoietin. And so a low hemoglobin is associated with high erythropoietin, because your body is like, get to work, we've got to make some red blood cells. So you'll see that those are inversely related to one another. Now, whether or not your body can respond to that erythropoietin and make red blood cells is a lot of times dependent on whether or not it has the basic building blocks besides erythropoietin to make red blood cells. So your body doesn't always respond to that erythropoietin with increased reticulocytes. That's what we would like for it to do, but it can't always do that. Now, if your body's trying to make red blood cells, this happens in the marrow, and so in a severe case of anemia, sometimes these patients will have pain as the marrow space expands in the sternum, as well as diffuse pain in the bones, because the marrow is expanding while it's trying to produce red blood cells. Any questions? So symptoms of anemia. I don't want you guys to memorize this table. I want you to know the symptoms of anemia, and sometimes knowing what causes it helps you understand those. I don't want you to say one is from decreased oxygen, one is from decreased volume. I just think it's helpful that the bounding pulses, because there is a decreased volume, that doesn't seem to make sense unless you realize that they're trying to compensate for the need for oxygenation to all these parts of the body. And then decreased volume, you really should associate with your postural dizziness and then syncope. Because they cannot, especially when they get up, they just have a decreased blood volume, and you can't create enough pressure to get that blood flow to the brain fast enough. So those people will have some postural hypotension and then syncope when they get up sometimes. So we're going to talk about the classification. So you can classify two different ways, and usually you'll use both when you're trying to determine what kind of anemia. So we'll talk about the first is pathophysiologically. So you'll think about anemias as those that are caused by red blood cell decreased production, and those that are caused by increased destruction or loss, like I mentioned before. And then reticulocyte will be your main hit here. We'll go into that in a few minutes about how you're going to use that. The other is morphological classification, and that's whenever you separate them into macrocytic, normocytic, or microcytic anemias dependent upon the MCV. The MCV, and I'll show you a decision table that I would encourage you to use, and honestly, if you just memorize the table, you go a long way to helping you determine or work out these anemias later on. And I'll show you exactly which table to spend your time on. But the MCV helps you separate anemias, especially and most importantly, treatable anemias, so that you can determine a treatment plan pretty quickly by helping you focus on which tests you need to run to rule them out between one another, and get you to a diagnosis pretty quickly. So the MCV is very important, and it's what you should look at, and almost always, when you look at an anemia question, they'll say normocytic, macrocytic, or microcytic almost immediately. So it's something that you'll see right away. So the retic count, looking at the retic count, that's when you're looking at the pathophysiological approach. Whenever you have blood loss, either from a GI bleed or some other acute bleed, or destruction of blood cells, the EPO is going to go up, and your body's going to say, make more red blood cells. And in situations where it can, the body will put out red blood cells as fast as it can and let out some immature ones, which what they look for the reticulocytes. They're just a little immature. In those situations where you're having blood loss then, the retic count will be high. Now, if you cannot make red blood cells because you don't have the building blocks, and guess what? The retic count will be low, right? I mean, this is just logic here. You can't make, if you wanted to, the red blood cells, so your retic count is going to be low. So the retic count, whenever you see that it's greater than 2 or 3%, that should tell you right then, this is either a blood loss situation or most likely a hemolytic anemia. And you need to start going down that thought process. And if it's low, most of the time, that just confirms for you that you're dealing with a decreased production problem. And you need to figure out which building block is missing so that we can give that to the patient and they can start building red blood cells. Okay, this is kind of hard to see, but maybe not on your screen. So this is where they look at the retic count first, which I don't find, I mean, it could be helpful for you, but most of the time I would tell you to look at the MCV first. So they look at the retic count first, and then after that they look at the MCV to determine whether it's normocytic or macrocytic. And you'll see there though, this is a good table here, where you see that the index is high, you'll see all your hemolysis or hemorrhage. What kind of situation's going on there, because that's a good differential to look at. And this one is a little easier, and I would spend more time looking at this, honestly. So the microcytic are what we're going to talk about today. On the microcytic anemias, these MCV is less than 80, they're small, and the first differentiating test that you'll do is a serum ferritin. Your ferritin, is your iron stores. And if your iron stores are low, well, that's kind of nice, because it leads you to an iron deficiency anemia and hit yourself in the face. Only those who are watching me got it, so you guys missed out. And then, but that'll be on video forever. That's awesome. And then the normal, this leads you to think maybe that's thalassemia, which I'll talk about. And your deciding factor there, the really definitive test is your electrophoresis. We'll talk about some other labs that lead you to think thalassemia as well, but your electrophoresis is your determining factor. And then you got here on the normocytic, you can see here they go to the retic count. If it's increased, hemolysis or blood loss, and then not increased, I think more leukemias or bone marrow issues. And then your macrocytic, which the main ones we'll talk about is your folate and B12 deficiencies. And I'll give you all the information you need to know to determine between those. So special considerations. This all seems really handy and kind of cut and dry. But you have some situations in which you can't always depend on your hematocrit and your hemoglobin to accurately reflect the clinical picture. One of those is an acute bleed. It takes a while for the hemoglobin and hematocrit to drop in an acute bleed. It can take up to 2 days. So you can't necessarily look at that and be like, there's blood everywhere, but that hemoglobin and hematocrit's looking stable. No worries. You can't use that as your measurement. It will take them 2 days for that to drop. The other is pregnancy. In your third trimester, your red blood cells and your plasma volume both increase. Unfortunately, the red blood cell volume only increases by 25%, and the volume increases by 50%. Now, if you'll remember, that measurement, your hemoglobin and your hematocrit, those are both over total blood volume. So because one is increasing more than the other, these patients will appear to be anemic, because their total plasma volume is increased. So it's what we call a dilutional anemia and not a true anemia. The other is in volume depletion. Those patients, so basically what it means is if you have a patient who is severely dehydrated and their hemoglobin and hematocrit look okay, you don't really know that they're okay, because that number is over total blood volume, which includes the plasma, and plasma is 92% water. So because that denominator is decreased, that number will appear higher than it actually is. So you can't tell until you give them some fluids, run some fluids through the patient, then recheck your hematocrit and hemoglobin, and you'll know where they're really at. Okay, so now that we've done that, I'm going to ask a few questions. This isn't for you guys to like, it's really not showing here. Do you guys find that these things work in general ever in here? Huh? Yes, no.
Not for the PowerPoints.
Not for the PowerPoint, it's just not working. All right, can you guys tell me, this is just for my own curiosity. I'd like to know how much work we got to answer yes or no.
Oh.
I mean, I could take a poll, I could do that too.
Do you have it open?
There's a question up there.
Okay. Or just raise your hands.
Yeah, let's just do raise.
Well, Howard, you guys are
It's
going to
not
be
open on board.
Oh, yeah, it's not open.
Yeah, it's not open.
Yeah, but,
No, that's for you guys to not see it. I don't care, I mean, I don't care, I want you to be able to see it, so I need this to work for later on. Is it active now? Sorry, guys. I have a few questions that you really ever aware is not actually good. All right. I think it should be gone, it should be open now. Never mind, I'm almost giving up. I think this,
Is it the second button?
Yeah. Seriously. Oh, no. Okay, good, that's my answer. But I have to be honest, I never had any before I came to PA school, so,
I like that you clarified for me.
yeah. I mean, dogs are all right, but it seems like nothing. Like, they just be like, I don't even know how they do it. It's like magic. You know what I mean? They just throw it in there, wherever. Have you guys ever done anything with dogs? Like, it's fascinating. Like, when they give IV fluids, they just run it under the skin. Yes?
I saw my dog get me to sleep. It was,
Yeah.
and it was stuck. I was like, and then it was very traumatizing. But I was like, it didn't even go in. Like, how did that happen? Yeah.
But the fluids, I had to do it. They were like, you need to give your dog fluids, and they just stick a needle under the skin at the nape of the neck, and just, like, it's like a huge bag of fluids that you just, this blood creates, and then it soaks in. Bizarre. So we had some people. All right, we'll go to the next one.
I think you have to press second button again, so.
Yep. Thank you. guys aren't afraid. I was afraid.
Yeah.
I was definitely afraid. I think it's okay to be afraid too, so for anybody wanting to answer yes anonymously, that's all right. Anything that requires you to do something so invasive to a patient should be concerning to you. You know, it should be, you want to make sure you do that right, especially if it causes them pain. Either way, they're going to have pain, right? Whether you do it right or do it wrong. I think that's the most frustrating part, that you could have pain and then nothing comes of it, which I've definitely have had experience. I've done that before. When I came here, the nurse quit within about 3 weeks, because I'm so easy to work with. And so I had to do all these blood draws myself. If you saw me as a patient and I drew blood, I'm really sorry. But it was really nerve-wracking to go from having somebody available for you to do that, like for 8 years, not drawing blood as a PA, because I was in family practice where I had a nurse available to do that, who knew what they were doing, and that was nice for the patient. And then I had to do it again, so that was really nerve-wracking. And I sometimes succeeded and sometimes failed, and that's all there is to it. All right. Oh, this is just because I have to plan something.
A vacation first?
I need to remember. Favorite vacation spot, tell me. Type it in.
That we wanna go to?
Iceland?
Wonder who that was.
Wait.
Where we want to go?
Oh, I
or
wanna go where
we've
we've been.
Either one, I guess. India. I have a few ideas. That's weird.
Oh, wow.
That's so cool.
With all of this
I went to Ireland.
Hawaii.
class of 2018.
Yeah, how are you?
I'm gonna put everybody's name on
Borat in Vietnam. Man,
Wow.
these are kind of all over the place. Chicago, that's easy to do. Whose favorite is Chicago? That's all right. That's okay. I mean, I let you. That's all right. I like Chicago. I've been here. I mean, I love it.
Let's go to New York.
I know, Costa Rica. Okay. All right.
Yeah, Costa Rica's closed.
Costa Rica
is my favorite vacation.
New York City.
Well, very good, guys. I'm not going to be able to do any of these, I'm pretty sure. But that's really awesome. And I'm wondering how many of you guys really have been to these places? Or is it just like, so most of you would say chose the place you've been? And you would suggest it? Okay. Well, I'm going to have to, Bora, is that what we call Bora Bora? Or just Well, I don't know. I mean, I really don't know.
The geography was very
I had some lady read my palm once, and she said that I was an avid traveler, and I'm like, oh, this is crap. I don't go anywhere, so.
Mom's crap.
Okay, that's really cool, guys. I'm gonna have to look into this. I don't know what I can get planned. I have to go on my 20th anniversary trip in July. That's all I know what we come up with. Really boring. That's what it is. Okay, so now's a nice break. Let's get back to it. Microcytic anemias. So these are all MCV less than 80, right? Remember where we are on that table? The kinds of anemias that we're going to look at today, I want you to focus on are your iron deficiency anemias, the thalassemia syndromes, and then anemia of chronic disease. I only list this here because 30 to 40% of them present in a microcytic way. So this is where we have a catch. Some of these will present both ways. You can't always count on a disease state to have always big or always normal sized cells. You'll find that in the normocytic as well, especially the hemolytic anemias, and I just tell you that because sometimes when you're looking at reviews, they'll classify them a little bit differently. I'll tell you when that happens, but some people will, some of the hemolytic anemias they'll say are macrocytic, but most of the time they'll list them as normocytic. But anyway, we'll go over that tomorrow. So anemia of chronic disease, I'm not going to go over in detail today. I'm going to do that tomorrow when I talk about normocytic anemias, because that is usually how you'll encounter it as a normocytic anemia. And then sideroblastic anemias, which are pretty, which have some pretty distinctive findings. The main initial differentiation you're going to use to set you off on the right course when you're looking into these anemias is ferritin, right? So, you did a ferritin level on this patient who had a microcytic anemia because their MCV was, their hemoglobin was low and their MCV was less than 80. We found their ferritin was high, was low, sorry. So, you think this is an iron deficiency anemia. Now this basically is when you have inefficient hemoglobin production because you don't have enough iron stores. Either they can't absorb it or they're not eating it, one of those reasons, and they can't make hemoglobin efficiently. You usually absorb iron in the duodenum and upper jejunum, and transferrin is what you use to move that to your blood stores. And transferrin moves it from your GI tract and then stores it as ferritin. So possible etiologies include, of course, blood loss, either usually a chronic disease. In men, we think some kind of GI problem. In women, it could be a GI problem as well, but you always need to consider the possibility of dysfunctional uterine bleeding, like fibroids, anything that causes heavy bleeding or lots of more bleeding than normal. We call heavy bleeding menorrhagia, and if it's happening more often than it should, we call that metrorrhagia. So either of those could cause, over a period of time, could cause an iron deficiency anemia. Your body tries to keep up for as long as it can in those states, and then eventually it just runs out of iron stores. And that's when you start to see the iron deficiency anemia. You could also have an increased iron demand as seen in pregnancy as well as nursing. Your body needs more iron during those times, and so it will start leaching more iron from its stores, and you'll find anemia eventually. And then malabsorption. Some patients who've had stomach surgeries, they lose their mucosa, which aids in the absorption. And then also inflammatory bowel disease can cause it because the cytokines will interfere with adequate absorption of iron. That also happens in B12 and folate deficiencies as well. And then you can have poor dietary intake, or you could be eating it, they could have a hemolytic anemia that then causes an iron deficiency anemia because your body has been keeping up with it by putting out reticulocytes and then runs out of your ferritin stores, and then it develops into iron deficiency anemia. All right, so these patients will have symptoms much like anybody else with anemia. They'll have pallor, fatigue, tachycardia if it got severe. But the ones that you'll think are a little bit different are pica, obviously, right? I don't know, Nikki, I'm certain, talked about pica yesterday? No? Yes? Yeah, okay, well, pica is where people eat things that they shouldn't, right? Like nails or dirt or clay or sometimes rocks. They think that this is because they're searching for a mineral which they cannot or they have not been able to get sufficient amounts in their diet, or probably if they ate liver, they'd be just fine, but they don't. They eat clay. So this is actual contents from a patient's stomach, all artfully organized. You'll see that there is some rust on those paper, on those safety pins, they're kind of getting there. But, and then koilonychia, which is the spooning of the nails, where they start to lift up and look like you could just eat right from them. Use them as spoons. And then Plummer-Vinson syndrome, and they don't know why this happens. We don't know why Plummer-Vinson syndrome happens. Like why these patients develop this webbing in their esophagus secondary to severe anemia. I wish I could describe the pathophysiology there, but it's not really clearly understood. But you do, if somebody were to complain of dysphagia, troubles eating, they feel like they can't swallow effectively, and they also had a low ferritin and a microcytic anemia, you need to consider that they might have Plummer-Vinson syndrome and get them an upper GI. They can go in and open that area, they can dilate it, These patients, interestingly, but not favorable for them, is that this is what they consider a pre-malignant condition, because these patients that are increased risk for carcinoma of the esophagus and pharynx. So you definitely don't want to miss it, so that you can give them warning and I can help them swallow. What do you order? You're going to do a CBC with differential usually. That's your first thing you'll order. After that, and after it comes back up normally, we'll talk about the peripheral smear and the iron panel, which you'll have them come back and do. Sometimes you can add a peripheral smear to a CBC with a diff. Sometimes you can, if you call within a day or so, they'll have the lab there and you can add it. It really depends from each lab whether or not you can add a lab to it. It depends on what you drew it in. They'll say, no, that needed a tiger top, or no, that needed a purple top, and there's nothing you can do about that. I'm like, all right, come in, we'll draw it in the appropriate container and send it off. So that's just so you know. Many times, if you want to know if you can add it, if it's been a day, they'll have the samples there, and you can look on the lab order and see what it was drawn in, and if it's in a lavender top, the same as your CBC is, you can be like, oh, call and add that, and they'll add it for you. But, or you can call and add that, and they'll add it for you, or tell you no. It's always worth a shot. So the CBC with differential, you guys know from your talk today what's on that. You have your WBCs, your red blood cell count, hemoglobin, hematocrit, or H&H, your cool kid, and then your red blood cell indices, platelet count, and then your specific white blood cells broken down with your SEGs, things like that. The peripheral smear is going to look at the cell. And you're going to do a smear of the blood, and you will look at it, not you, somebody who knows a lot more than you do about these things, will look at it and tell you about the size, the shape, is there anything abnormal, the blood cells have nucleuses when they shouldn't, things like that, and then write your report. So here, we have a peripheral smear. This is a normal peripheral smear. It's a neutrophil. These are your denucleated red blood cells. They look pretty good. You have a few that come out, that's all right to have a few nucleuses, but they shouldn't be predominant. And then you have small ones. These are small. And they're also pale because there's not enough hemoglobin in them. So that's one of the main differentiating factors in an iron deficiency anemia. What you'll see is the small pale. Another thing you'll see, in which maybe, I don't know if you can determine here, is there's lots of different sizes for anisocytosis. You have a lot of different sizes of cells because you have different amounts of hemoglobin. Like sometimes they'll have hemoglobin, they'll have enough, the ferritin to put in the cells and make hemoglobin, and then other cells won't, so they'll be smaller. So you'll put out lots of different sizes, which means your RDW, or that's the differential between the widths of different cells, will be greater in iron deficiency anemia. Here is a peripheral smear, and this, I just wanted you to show you, this is an EMR, electronic medical record, and they draft. So what will happen whenever the pathologist looks at your blood sample, it has all these different things to choose from, and then he'll put one in here and then make all the changes specific to this patient and then send it to you. So you'll get something that looks like that. The peripheral blood smear shows normochromic, normocytic anemia. So don't expect that you're ever not gonna send you a picture that you have to be like, what does this mean? You'll get a report, but you need to know what that report means. You need to understand that they usually give you a differential to work from in the end. Sometimes the differential is so all over the place that you're like, thank you very much. I'm right where I started. But usually it's pretty helpful. So iron panel studies. It'd be awesome if you could just say, I'd like an iron panel. That is usually not the case. What do you absolutely need to have? You absolutely need to have the serum iron, the total serum iron. You need to have your total iron binding capacity. You need to know how can this blood bind iron if it wanted to? If it was there, could it do it? Transferrin saturation, which I wanted you to see that is a total serum iron over TIBC, because that's another ratio and it will go up and down based on your TIBC pretty dramatically. And serum ferritin, and then if you thought this is really significant or this patient wasn't responding, you might consider sending to hematology so they can get a bone marrow iron stores. Now, thankfully, from many studies, they've determined that your ferritin level, serum ferritin, correlates very well with the ferritins that they find in bone marrow biopsies. So we don't put people through that because we have a really handy blood test we can do to test for ferritin. But if it were that severe and you felt like we need to figure out if there's another issue or maybe there's a hemolytic issue on top of this iron deficiency anemia, then you need to send that person to oncology so they can look it up. So here's a little snapshot of all of our labs in iron deficiency anemia. Your H&H will be decreased. Your MCV will also be decreased, because this is a microcytic anemia. On peripheral smear, they'll be hypochromic. They don't have enough hemoglobin. They'll be microcytic. I mentioned before, they'll have anocytosis because they have lots of different red blood cell size, also due to the variations in hemoglobin. Cytosis, that basically means cells are all different shapes. Sometimes they're not appropriate, sometimes they're not spherical, and they have some target cells. I don't know that I really want you to spend a lot of time looking at that. But just, you should know that poikilocytosis, what that means for your own sake whenever you're reading something. And your total serum iron is going to be low. You will have an increased TIBC. So if you had the iron, TIBC, you know, is your bus, right? It's there, it has all these seats on the bus, and it could take iron somewhere if there was just iron to be had. So if you have a high TIBC, that just means there's a lot of seats on the bus, and no one's getting on, right? And then your transferrin saturation is going to be low. Why? Because your TIBC is so high, and that's the denominator in that lab. And serum ferritin will be low as well, because those are your iron stores. We know that those are low. Your RDW is going to be high, because your blood cells are creating all different sizes. So that's the differential in blood, in your blood cell width, and that's going to be high. There's going to be a high differential. Also, we know that because of the anocytosis. So the nice thing about these labs is if you understand them, your peripheral smear starts to make more sense. It's like you could actually, by the red cell indices that you get on your lab work, you could kind of predict what the peripheral smear looks like. So it's actually kind of nice. You're not always going to get a peripheral smear. Most of the time, actually, you won't. You should be in an iron deficiency anemia. It's worth a shot looking at it, but you're not always going to have that available to you. And so it's nice to know that on your red cell indices, you get a lot of the information that you would get from a peripheral smear. Other labs to consider is a retic count. And in this situation, the retic count is going to be low, right? Because we don't have the building blocks we need. And then this is where it gets tricky. So you're really proud of yourself. You know you have an iron deficiency anemia. And guess what? It's just starting, right? You can never diagnose somebody with an iron deficiency anemia without what? Figuring out what caused it. Right? So now you just know they have an iron deficiency anemia, which means their body is not keeping up with their iron demands needed to replace their red blood cells. So either they have a problem, they need to fix their diet, which would be awesome if that were the issue all the time, because that's pretty simple. And also giving them their iron supplements is going to fix that. But you need to make sure this patient isn't having a GI bleed that we need to look into. Do they have a celiac problem, an inflammatory problem that's going to affect them, that they're not going to be able to absorb iron forever? Do they have dysfunctional uterine bleeding that we need to look into? And do a UA, make sure they're not losing blood in your urine. There's a lot you need to consider. It is not a diagnosis that you just get to sit back on your laurels. You're just starting whenever you have an iron deficiency anemia, which is a story for another day. I just want you to know that you cannot quit there. So treatment, you treat with oral iron replacement, the 325 by mouth 3 times a day. It is terrible. That is the treatment. I'm going to tell you, that's the treatment right there. It'll always be the treatment. On every test you take, that will always be the treatment. Hardly any patient will ever actually do that for you because it is hideous. They never poop again. It makes them nauseous. They don't want to eat. No one wants to live this way. So it's always worth a shot to start that. But always tell them these things. Take it on an empty stomach, don't drink tea, and take a little vitamin C or orange juice. This will help you with absorption and get them more bang for their buck because they're miserable, so we want to make sure this helps them as quickly as possible. You wanna warn them that their stool's gonna turn really dark so that they don't get freaked out about that. But if they cannot take 325 TID, which most people can't, studies have shown that they can actually get a really good return. It's slow, a little bit slower, but a lot more likely to continue treatment at 100 BID twice a day. And if you can start at 325, but tell them it might be difficult. And hey, if you have trouble, I'm willing to negotiate. Let's come back and talk about it if we can't get it done. Because it's important that we get this solved for you so you can start living life normally. But 100 BID is usually, it does help them, it helps them, I guess, soon enough that they continue treatment. Because it's always a balance between patients. They want to know that it's going to help them, and if they don't feel like it's helping, they won't continue that either. So we have to kind of figure out the balance between can they handle the side effects, and will they perceive a difference in their health. Okay, so it can take 2 months for the H&H to actually regulate, so that's not going to be your earliest indicator, but you're going to continue treatment for 6 months. The earliest one is a retic count. Because now they have the building blocks, your body was already trying to produce red blood cells, so your body starts kicking them out now that you got iron. So the retic count will go back up within 7 to 10 days. So if you want a good indicator that you're getting where you need to go, maybe you've decreased their amount and you're worried that maybe it's not going to be therapeutic, go ahead and run a retic count. And that's going to give you your earliest indicator that A, this is the right diagnosis, and B, they're taking their medicine. We're getting to where we need to be. If they can't tolerate oral therapy, then you should consider parenteral or IV therapy. If they're not getting better, then think I may have the wrong diagnosis. They may not be taking their meds. And there could be another issue going on, so you need to rethink it. All right, any questions about that section? Yeah.
How come excessive menstruation is considered an iron deficiency anemia instead of a hemorrhage anemia?
Well, I'll tell you, it's kind of similar. It's just that it actually leads to, the retic count is kind of your key there, because it's not actually able to replace the red blood cells like you can in an acute and a hemorrhage. Do you know what I mean? Because you don't have the building blocks. So that's why it's microcytic. And in a hemolysis situation, your retic count is high. I think it's mainly just because there's something else going on. Because it actually would be a high retic count until it lost the iron stores. Do you know what I mean? It tries to build up, it tries to keep up as long as it can, your body, and then eventually it runs out of iron. And so until that point, the retic count probably was high until it lost the iron, and then it went down low, and then your iron stores were depleted. I don't know if that...
So would you find something similar to that in a chronic bleed?
Yes. Yes.
So would a chronic bleed also kind of fit under the iron deficiency type?
Which is why you cannot say it's iron deficiency anemia, we're good to go. You have to look for the chronic bleed because you've got to solve that problem too. Or they're just going to be right back where they're at, and there might be something much more sinister going on that you have to address. So, any other questions? All right, you guys are doing pretty good. Staying with us. All right, thalassaemias. So, I know that you went over a little bit about thalassaemias. No? Nothing at all? Nothing about hemoglobin or how it forms a tetramer? Okay, so we'll go over it. So I'm obviously going to, but I'm going to give you a little bit of the pathophysiology as well. So your red blood cells are made from hemoglobin, and your hemoglobin has 2 alphas and 2 beta chains. It forms a tetramer. That's how it correctly functions. That's in the perfect world of non-thalassemia syndromes. However, in thalassemia syndromes, there's a problem. Either they're not producing enough of this D chain in beta thalassemias, or they're not producing enough of this alpha chain in alpha thalassaemias. Now, we have a lot of different genes. I mean, let's see, I'll go through. And alpha thalassemias, there are like 4 genes, and beta thalassemias, there's 2 genes that code for the production of these globins. And so whether or not you've lost 1 or 2 or 3 genes really changes how severe this disease is. And I'll go over those specifics, I promise. So basically, this disorder is when you have a deletion or a mutation in any of the genes that code for normal globin production. And so we usually have the 2 alphas and 2 betas. They have to bind to one another. And when you don't have that, either they start binding to the alpha, the gamma, and delta, and other globins that are a lot less frequent in your blood normally, or they bind to each other, which makes very unstable. They don't like to do that, like A and A and B and B, so you have a tetramer of all Bs. They don't like to do that. Alphas can go and bind to gammas and deltas, which is okay. It's not ideal, like an alpha beta is, but they can do it, and your body will make do to a certain degree with that hack. But it won't produce hemoglobin the way it should. It won't move oxygen the way it should. Oxygen won't bind to it as tightly. The other problem is because it's not bound appropriately to a beta, an alpha beta, it will break down. It will oxidize, they'll become attached to oxygen, and then disrupt the cell. So the red blood cell will sometimes lyse because it's inappropriately bound, the hemoglobin, to other things other than another globin, and you'll lose red blood cells. So we have the alphas and betas, and I'm going to talk about this. I think it'll become clearer as we talk about it. So why do we have thalassemias? Why does it exist even in the human populations? Well, what we found is that thalassemia actually gives you a protective effect in areas where there's malaria. And so where you'll see thalassemias, and alphas and betas kind of show up in different parts of the world. Betas, I'm trying to remember, get that right. I think betas are Mediterranean mainly, and alphas are the Asia, China, India, Africa more commonly. That's not important for you to remember. But the point is, it has a protective effect for malaria, and so it continues in areas where there is malaria, that this genotype continues in the population, and it's passed down because it's selected for in those areas. Especially since most of the time, what you'll find with these thalassemias, most of the time they're not even symptomatic. So it gives them a pretty good protective effect for little cost most of the time. So alpha thalassemias, the first one, a mutation of 1 or 4, so you have 4, right? This is on chromosome 16, I believe, yeah. On chromosome 16, you have 4 different genes that code for your alpha globin. So you'll see that the severity depends on how many genes are affected. It even goes more detailed than that. You do not need to know it, but you might see that in some of these, even a point mutation is worse than a total deletion. And those genes like hemoglobin B disorder, you'll see that there might be some discussion about what gene deletion or what gene problem and the severity. Don't worry about that. You really just need a basic understanding of these, so don't go down that rabbit hole if you see it. But basically, because it's affecting the ability to produce alpha globins, these patients will have too many beta globins. They won't have enough alphas to bind to the betas. So the betas will start binding together. In silent carriers, there's 3 functional alpha genes and only 1 gene is affected negatively to where it can't produce the alpha globin. So most of the time they produce enough alpha globin to sufficiently bind with the other beta globins to create tetramers. And these people function like normal. They're silent carriers, they don't know it. The only issue is that they could pass this on to their offspring, right? They have one of their genes are gone, and so potentially they could pass this on, especially if one of their children had children with somebody else who was a silent carrier, and that's how we see this propagate. Because there are so many silent carriers compared to the actual symptomatic
Is
patients.
there any chromosomal testing that they can do to see if it's
Oh,
going to
yes.
be passed down?
Yes, and they don't usually do it unless you have a history, either a family history where you know somebody had like alpha thalassemia major or intermediate. You don't usually do it, but yes, and I'll tell you when you would, for sure. So alpha thalassemia trait is when you have 2 functional globin genes, and you maybe have 2 missing. So now they've decreased by half their ability to produce alpha globins. These people generally, sometimes they really do not have any symptoms. They might, this thing about these patients is that they may have periods of time where they have less alpha than normal, or what happens is sometimes they make do, even though they only have so much alpha binding with the beta, and the rest of the time beta is binding with beta. So say you have half that are alpha beta tetramers, like they should be, and half of your red blood cells have beta 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 beta, right? So 4 beta, it's not great. But because there's enough, they're fine. The only problem for these people is whenever they have an infection or they take a drug that oxidizes the beta beta tetramer and destabilizes it, and then they start to they crash for that period of time. But usually it doesn't happen long enough that you even find out they have a problem, especially with the trait or with the trait especially, and alpha H it will, but with the trait, and then they'll go back to normal. Like that exposure's gone, the infection's cleared up, and then they'll go back to their normal alpha alpha tetramer, beta beta tetramer, that functions good enough. So hemoglobin H disease is actually, is where you have only 1 functional alpha gene and 3 dysfunctioning. So they have some alpha beta tetramers, but then they also have a lot of beta beta tetramers, which means these people could have episodes where they have very severe anemia. But many times with hemoglobin H disease, they actually don't need treatment. They don't need transfusions. It's very rare for these patients to need transfusions. Usually it only happens whenever they have an acute oxidizing agent, like sulfa drugs, that come in and break down all of their very fragile beta-beta tetramers, or they have an infection. But it has to be very severe to cause that problem. So in that situation where their anemia gets very low, you might do a transfusion. Now, one thing that you guys need to know is, should I close that door? Okay. Really? One thing you need to know is that because the hemoglobin, you have all these beta betas, it doesn't use iron like it should. So these patients, although they have iron available to them, they can't use it. So they will have high serum iron that they're not effectively incorporating into hemoglobin. And it will put them at risk for actually dangerously high levels of iron. So especially in situations where they're exposed to when they get blood because they have to, because they are in a crisis of some sort, you have to really watch their iron levels after a transfusion to make sure that they don't get dangerously high. So sometimes they have to give them chelating agents to bring down the iron concentration in their blood. You always watch for iron overload. Anybody with thalassemias, you gotta watch for the iron issue. Okay. And then alpha thalassemia major, which this is different, I added stuff, so I'm sorry if you, I will definitely replace whatever is on the server. I won't do too well with this one, but I wanted to put in these other names because I always think of it as alpha thalassemia major. But what you might see whenever you're searching for these things and looking at them is that it's also called hydroxyfetalis or Bart's hemoglobin. Those are just all synonymous words they use to describe this one condition. And that's where there's no functional alpha globin genes. And these patients don't usually survive, usually die in utero, unless they get intrauterine transfusions. And then after they're born, they have to receive repeated transfusions. Sometimes they will get a stem cell transplant that can treat the condition. But it's very controversial, this whole treatment of patients with alpha thalassemia major, because usually by the time they're born, they have severe developmental difficulties, and so you can't predict what's going to happen when they're born. You don't know how severe the developmental difficulties will be, and you won't know for some time. So they don't always treat this, and most of the time, they don't even know, right? So when you would find out, or when you would consider that somebody might be experiencing or having a problem with this is repeated miscarriages, right? Whenever they have repeated miscarriages especially, and that's why you have some questions about that whenever you do your genetic counseling, about somebody with repeated miscarriages needs to go to genetic counseling. One, so they can figure out, do you have a history of thalassemias? Do you have a thalassemia that you don't realize? Because they could have